bonjour à tous. Bonjour à toutes. Bienvenue à cette présentation sur le eForm Project. Mon nom est Frédéric Laroche et je suis vraiment heureux d'être avec vous ce matin aujourd'hui parce que ça faisait longtemps que je voulais organiser une présentation sur le sujet. Donc, j'ai eu la chance d'être impliqué sur le projet de la Colombie-Britannique dont on va parler tantôt, il y a quelques années. Et puis, j'avais trouvé le projet vraiment inspirant et aussi qui nous apportait des nouveaux horizons et des nouvelles possibilités. Donc, j'avais à cœur de partager ça et de le présenter au Québec afin qu'on puisse s'en inspirer. Un petit point à préciser peut-être avant qu'on commence, c'est que dans cette présentation, on va parler de deux implantations distinctes du projet eForms, donc une en Ontario et une en Colombie-Britannique. Et puis, c'est ça, ces deux implantations qui sont fonctionnelles et en prod actuellement. Donc, juste pour être bien clair que ce qu'on va parler aujourd'hui, ce n'est pas nécessairement le futur ou une vue de l'esprit, mais bien quelque chose qui existe actuellement et qui est déployé. Mais au-delà du cas d'utilisation spécifique dont on va parler aujourd'hui, c'est-à-dire les formulaires électroniques, notre but, c'est vraiment de vous inspirer en démontrant de façon concrète ce qui est maintenant possible de faire en utilisant Smart on Fire. Donc, ce que je vais vous demander, dans le fond, pendant la présentation, mais aussi après, c'est d'essayer d'imaginer quels sont les autres cas d'utilisation qui se prêteraient bien à l'utilisation de Smart on Fire et des autres principes dont on va parler aujourd'hui. Now, let's meet our panelists, starting from my left. Dr. Ian Bekker, family doctor at Vancouver Island Health Authority. Hi, Ian. Chris Mota, senior manager of technology solutions at Ontario MD. Good morning, Chris. Oliver Thompson, Director of Provincial eHealth Project at PHSA in Vancouver. Hi, Oliver.
Bonjour tout le monde.
Andrew King, Chief Technology Officer at Ontario MD. Good morning, Andrew.
Good morning, everyone.
It's a great pleasure to have you here in Montreal, and thank you for being here. It's really appreciated. And without further ado, let's dive right in. Ian?
Thank you very much. As a physician, whenever I need to get a service for my patient, I need to fill out a form. And these forms, if you can believe it or not, are still designed for paper and pen. But all my data is on my EMR that I need to get onto the form. So somehow I need to get the form into my EMR. And that's pretty complicated. I can do it, but it takes a lot of time and a lot of effort, and it's very fussy. Or I can pay someone to do it, which is a lot of money that I don't want to spend. And then once it gets in there, it's really hard to work with. It's very difficult. And then what happens is I start using it, I start sending it out, and then in 3 weeks or 3 months or 6 months later, I get a note to say, hey, you're using the wrong form. Oh, so then I have to go and do that whole thing. I have to go find the form, then I have to like digitize it, put it into my EMR, and it's such a pain. When I go to send it sometimes, I don't even know it's got there, so I have to ask my MOA to go check to see if it's gotten there. So I characterize using forms like wearing an itchy sweater all day. You're just like, oh, another form. I hate forms. They're such a pain. We need to do something better about this system. It's just not working.
And from the form owner's perspective, it's equally frustrating. There are, keeping track of whatever the latest form is, there are thousands and thousands of clinicians who are filling these forms in, and you're managing every one of them individually. A lot of these things are coming in fax, right? Still, that fax word. And we're translating from paper into the information systems. And so, and it also, now I've got some changes, I've got some modifications I need to do. It takes forever then to propagate that new form out to all of the clinicians who need those forms out there in the system. And so, and then I also have to, a lot of times I have to pay the vendors as well to actually do that too. And so that it's entirely frustrating even from the health systems perspective. And we've got to find another way.
I agree. In fact, I'm going to suggest we need a forms renovation. Just like you do a kitchen renovation, where you think about, what kind of cupboards I want and what paint, and I want to move the appliances around. I think we need to do that for our whole form system. But in order to think about that, we need to divide the form system up into 5 things so we know exactly what we want to change, what color, what brand of equipment we want to buy. So I'm going to divide it up into the forms themselves, the searching system for the forms, how we view the form and complete the form, and then how we send the form, and then how we track the form. All right. So we have to think about, well, what would an average physician want? I'm going to propose what the design should look like. When it comes to the forms themselves, really, really important that at the end of this renovation, there are no stale forms. Every time a physician goes to reach for a form, it's always the right form. And then also super important by the end of this renovation, all that data in my EMR needs to go onto the form. And I want it to go on quite smoothly. I don't want to do any work, and I want it to be even more complete than it is now, because right now it's not entirely perfect, the data getting on the form. But then there's two things I don't really want to change too much by the end of this renovation. The first one is the searching. Right now, I search in my EMR. It's integrated into my EMR. It's available in various parts. It's easy. I'm familiar with it. It works well. And I don't, as we're transitioning in this form system, I don't want to end up having to search in two places. So I just want to stick with my EMR. I'm really comfortable with searching right there. So that's one thing I don't really want to change too much. And then when it comes to sending, I want to make sure that there's a copy of the form that comes back to me. I currently have that now so that I can go look up what did I say on the form. So we need to keep that. And we also need to keep it just as fast. Like right now, sure, it's fax, but I just hit eFax, zip, and it's gone. And so I don't want to have any more complications with this new renovation. But if we are going to do a reno, I'd like to have one super cool feature added on, and that is I get a note back to say form was received so that I don't have to go chase it down. How does that sound?
Awesome.
Good.
Let's see if you get it.
Let's do it.
And to carry on with this then from the form owner's perspective, and once again, I'm not really interested in the PDF, right, or the paper or the fax version. I want the data, right? I want to be able to take the data that's coming in. I want to be able to use it in the circle of care, transition of care, so that's not just trapped within that individual form itself. And as we're putting these forms out, I'd really love to just put it out in one place, so then that it's available system wide. So we need a much more effective way of managing the updates to these forms themselves and making it so that all of these forms, we've got thousands again of clinicians that are sending in these forms. And so we don't have to manage each and every individual instance of those forms coming in. They're all using the same version. Wow, imagine that. And so that's the venture that we came on.
Okay, but wait a minute, guys. That's a great wish list and all, but remember we have limited time and budget for this renovation, right? And like for all big renovation, the grand ambition needs to come to term with reality. So we might need to be willing to let go of some of the dreams, delay them, and focus on being convincing about what we really want.
Okay.
And to help with this renovation, we have brought two sharp-eyed designers, both with recent experience in form renovation in BC and Ontario, Chris and Oliver. They don't look alike, though. Go ahead, Oliver.
Great. Well, thank you. Thanks for having us, and thanks for the opportunity to try and actually, come up with a solution that you guys can actually live with. So, next slide, please. So, so Chris and I, we had a chance to sit back and go through our collaboration, figure out what we want to do, and I think we have something which you guys can actually enjoy.
All right.
Forms. Centralized repository. So one place where all the forms actually sit and everybody has access to it. Okay. So then everything, the form is always up to date all the time. If it's updated 5 minutes ago, 5 seconds ago, a year ago, it's always up to date. Dr. Bekker, no change to searching.
Okay.
So you know what? Your workflow is exactly the same. We don't want to confuse anybody. We'll
Nice.
make sure we don't change that. Guided workflow and mandatory fields for the form itself. So this is gonna both simplify the user experience in actually completing the form. So you get these long forms, and it's section 1. If this isn't applicable, go to section 8. So you got all this extra text on a paper form. Well, let's get rid of all of that. Let's actually just say, if you say no to a question, well, don't present anything else. And if you say yes, then some more information appears. So guide the workflow. So it simplifies the user experience. But from a system perspective, we got to make sure we get the information that we want. We don't want to actually have any information, any forms coming in that's like, oh, well, they didn't answer this question. Damn it. Which is entirely happens within the paper world. So mandatory fields so that we make sure that no incomplete forms go back. Data. You want data?
Yes, please.
We will send you data. We will send you data.
No way.
Yes, that's the goal here. So 4 out of 5. Can we hold it there, because you know the tracking, the coordination, that's a little bit of extra. Budget wise, we might have to hold on that for a while. So sound good? Okay. So Chris, how are we going to pull this off?
All right. So obviously, with any renovation, you're starting with the base of everything, right? We'll worry about the spit and polish in a second. Let's start with the fundamentals. Now, as we're talking about all of this, usability is key, right?
Okay, yep.
We're talking about, I want to be able to go from here to there in a seamless experience. I don't want to have to worry about all of the extra stuff. And so what we started with is Smart on Fire. In this case, Smart on Fire, what it is, it's a framework. That's what we're ultimately talking about. It's just a way for applications to interact with other applications in a standardized way. Nice, secure base for the different systems to interact with. The added bit that we're going to put on top to make things a little easier for you is actually we're going to layer on some single sign-on.
Okay,
Let's do that too,
let's do that.
right?
Yeah.
Because who wants 17 passwords and usernames and
Definitely don't want that.
shoot, I didn't use this one in a week. What was that again?
I checked the sticky note for my computer.
So we'll throw in your single sign-on. We're going to plug it in. We're going to use Smart on Fire. We're going to plug it into your EMR.
Right.
And we're going to make it a nice little button. You can click on that and pop up. There you go. There's your eForms. Now, the one thing I got to be very careful about here is it's not that it's zero effort.
Right.
Let's be fair. Nothing is ever zero effort, right? But the interesting tidbit is Smart on Fire, because of the application interactions it has and that standardized framework, you end up in a situation where it becomes more of a plug-and-play scenario. It becomes a little easier to go back and forth on. And that just means that, hey, you know what? I don't just want eForms. I want a consult. I want something else. Well, that's a standardized integration. We can plug that right in, right? But it's great that we're looking at your stuff.
Yeah.
But I got to worry about Andrew too.
Okay, fair enough. Little
Yes,
bit.
please.
He's my boss. I got to keep him happy. So let's then talk about not just the pane of glass for the doctors, but what does it mean on the other side? So Smart on Fire is based off of FHIR. Okay, FHIR, for those not familiar, is the Fast Healthcare Interoperability Resources. Long and short of it, it's a structure. It's a data structure. Okay, but it's a nice standardized way to organize concepts for a patient, let's say. So first name, last name, date of birth, those are things that are pretty standard. You know, whether you're providing the care or receiving the forms, you need the same stuff. So it's a nice way to organize and collect everything and transmit everything. But here's the key. It's not PDF. It's not fax.
Nice.
You're going to get individual data elements. There's going to be a field that says patient's last name. There it is, right? This, of course, lets the system side, Andrew's side, do things a little bit faster, right? I no longer have to worry about typing it in. I don't have to worry about, the delay between, it came in on a fax and, well, I only pick those up at 5 o'clock and I type it in the next morning. That allows for the pre-population into the destination system. It allows for auto processing of certain forms if you build in that logic, which ultimately turns around and lets you get a response faster.
Oh.
It lets your patients get into the system faster, just makes the experience better for everybody all around.
Okay.
Best part about all of this, if built in both directions, it's not just your data going to him, but his response is coming back to you.
Nice. Okay.
And all of a sudden now you got data coming back. It can get populated into the correct spots for you.
Okay. Form received. Nice.
Cool. So lots of talk about theory and ideas. Let's actually give you a picture so you can see what this actually means. So I'll just walk you through a couple workflows here. This assumes this is post implementation with an EMR. So the EMR is actually set to actually be able to communicate using Smart on Fire to our form process. So infrastructure, we'll just walk through some pictures. And there's two parts here. There's the administrative workflow, which is really the setup side of it. That happens sort of at the very beginning. And then there's a clinical workflow. This will happen sort of every patient encounter that actually happens. So start off with a service provider, a form owner. So it could be a hospital, a ministry, an insurance company, whoever has a form that they need populated. Okay? So that form owner, they are responsible for their form. They create it. They do updates. They go through their clinical validation to make sure it's the smoothest form out there. It makes sense. They do all that guided workflow stuff. We can help them with that, but ultimately they're the ones who have responsibility for that. They take that and they put that into a central form repository. One repository for the system, for your province, Canada, and it sits there and it just waits. And then we also make sure that the EMRs are aware that form is actually sitting there. So this is some back communication to say, hello vendors, there's a new form that's been populated here. It's available in the repository should your users actually need to get access to it. So nice, easy setup. Great, the form is sitting there ready to be used. Dr. Bekker has a clinical encounter with a patient. Oh, there you go. Need to have a form, need to complete it. We want him to search the way he searches today to find that form. But the EMR, she knows, oh, look, it's not the old form. That's just the scan of a PDF with fields put on top of it. This is actually a form in the repository. So he clicks a button, it launches the form. Dr. Bekker doesn't know that it's actually not within his EMR. It might look a little different, but you know what? It's just from a workflow perspective, the same process. Click, oh, there's my form. Oh, there's the patient information that's in there. Oh, there's the provider information that's in there. Oh, there's some other clinical information that's in there. Let's grab from the EMR. And he goes through that experience to actually complete the rest of the form. As soon as he presses the button, then two things happen. Andrew, from a system perspective, gets that completed form with the data sent discreetly into their systems so that they can actually use the data. And Dr. Bekker gets a copy of that back in his EMR. The EMRs and the systems, they do have options, so they can take the real data and actually put that in. Definitely from a form receiver perspective, form owner, that's what they want. From the EMR, maybe they just want the PDF. Just for a record of this is what it looked like. So, but there's options there because they also get the data. So going back to our analogy, you've got the forms in the form repository. You got the lookup side of it, our viewer, and then our transport system there. So going back to our requirements. Okay, let's see how we did.
All right.
Latest version, form all in the repository all the time. We happy?
Yep. Check.
Check. Look at that. We didn't touch the lookup too much. We didn't require you to go onto a different place, sign on with something else. Same as before. Check. Okay. Data. Data. You like that? Check. Okay. And as easy as facts. Nice. There you go. Fantastic. So 4 out of 5. And again, we haven't touched the big upgrade on the tracking system. We'll get to that later on.
They liked it.
They liked it.
Awesome. So you agree with the overall plan. Let's see how the Renos look in BC and Ontario. Let's discuss about the real implementation. So in my day-to-day work, I have the chance to be involved in many projects throughout Canada. And I must say I was very impressed on how these two projects got together. So now let's see what the renovations look like in BC and Ontario. Over to you, Chris.
Thank you. So as we mentioned, this isn't just theoretical. This is something that has actually been built in these two jurisdictions. Starting off, to give you a little bit of background, Ontario MD was approached by the Ministry of Transportation in Ontario, and we were asked rather, to help them get these forms in a digital capacity to clinicians. Now, as with many of these organizations, their first thought was, hey, we'll stand up another portal and we'll give people logins and everything will be great. It'll be fine. We can stand it up in like 2 days, right?
Ian's need more password. Right?
He needs more post-it notes on the screen. That's fine. So while the Ministry of Transportation did go off and build their own portal, the reality is, sure, go do that. We worked with them collaboratively over a period of some months to develop the integrated Smart on Fire approach for the EMRs. Now, keep in mind, where were they starting from? They were starting from a scenario where fax was daily life, so was Canada Post.
Right.
Keep in mind, in Ontario, you're talking about thousands upon thousands of clinicians, millions of patients. Just the scale of magnitude was just immense. So, okay, we turned to the ministry and said, let's bring it in. We're going to turn around and do this right. We're going to help you guys out. And so we took all the frameworks that we talked about, the Smart on Fire, the actual fire data structures, and we put together an implementation for them that turned around and started off with one form, eventually grew to 28 forms, and then an English and French version of each, of course, right? Today, that same eForm solution now services 13,000 clinicians. It's integrated into 10 of the 13 certified EMRs in the province of Ontario. And it was actually so successful in this case that not only is eForms integrated into the EMRs, there's actually a total of 5 different services using the Smart on Fire framework here that connect into the EMRs directly. And it's as simple as, here's a button in a patient's chart that will take you to the service you need. Everything from that eForms to what we call SAR reporting, which is cancer screening reports, to community care services, and where you can check in on how your patient's doing on those. So let's actually take a quick peek. So in Ontario, as I mentioned, you go to, if you're a clinician, you're working in your EMR, you're in your patient's chart, and you go, you know what, I got to send that form. Honestly, it's just, I need to, or the patient walks in with something and says, hey doc, I need you to fill out this form so that, I can continue doing this, or I can go there. And so in the patient's chart, little button in the corner, eForms. Click, and here you go. You're off to the eForm service. That eForm service is actually integrated in such a way that the clinician can actually choose whether it's displayed as part of the EMR, effectively a window that will pop up in the EMR itself, or as an external service that they can put side by side, completely configurable by the clinician themselves. In the eForm solution, they get the ability to select a line of business. So I need to send to Ministry of Transportation, I need to send to this hospital, that hospital, whatever it is, before they're given the ability to search for a particular form that they need. Once they've done that, they end up on a demographic screen entirely pre-populated for them. First names, last names, addresses, phone numbers, clinician identifying numbers, all of it. All the clinician needs to do is peripheral glance, make sure nothing looks out of the ordinary, next, before they get into the guided experience for the actual form itself, the actual data that the receiving system is actually asking for. Okay, and as Oliver mentioned, guided experience. You start off, it's one question. Oh, now you answered, C instead of D. Here's 2 more questions. And you only ever see the questions that are relevant to the workflow that is applicable to that scenario. At the end of the solution, they hit submit, real-time submission into the back end. They get a confirmation on the screen that says, hey, look, it's been delivered. You're good to go. Here's a confirmation number in the green at the top. They have the ability to print if for some reason they'd like to print it out. Maybe the patient's beside them and they want to give the patient a copy. Here you go, print, off you go. But to make things easier for the clinicians, we then take that completed submission that was sent to the back end, and we utilize other services in Ontario, specifically one called Health Report Manager, that will take the completed report, funnel it right back into the EMR, directly into the patient's chart. It's done. All of it.
Beautiful, just beautiful. Now this is where I have a little provincial envy. They went big. You guys are much bigger than us. We're just BC. But you know what? Equally exciting opportunity and implementation in BC. So we started with special authority forms. So these are forms that physicians need to complete to get access to expensive, rare medications.
Yeah, cheaper for the patient.
Cheaper for the patient. Okay. So so the special authority process, I don't think they used mail, but fax, definitely fax. There was definitely lots of fax. Around 300,000 requests coming in a year. And that portal fax machine was just getting backed up. On any given time, they would have about 20,000 faxes in the queue to be processed. And you can just imagine, it's all a manual process. So there are people, and I'm sure it's in Quebec too, whose job is to take the fax, type it in, scan it. Ouch, that sounds painful. So so we started to work with them to digitize their process. Now, special authority forms cover a whole raft of medications. So from a paperwork perspective, there's probably around 300 variations of these forms. So we worked with them and basically took it down to one. So guided workflow. What's the medication that you're looking for? Okay, great, fantastic. Next section. Okay, this. Okay, next section. So from a Dr. Bekker's perspective, he's not looking for, well, where's the special authority form for this drug? It's irrelevant. Special authority form. So we simplified the whole process. And digitize it, sent the information back to their backend system. They worked to consume the data and actually put it into their system. And one thing that they did to optimize the workflow is put in the auto adjudication processes. So when the data comes in, it reads the data and says, yes, you checked all the right boxes, you gave us all the right information, approved. Just like the bank loan, what you want. It's all fantastic, approved. So the success from this implementation, so I just pulled out two stats here. Incomplete forms. So this is the mandatory fields and making sure that all the forms are all the information that's actually required is collected by through the form. So prior to this, they had an incomplete rate of around 27%. So that means 27 of 300,000. It's a lot of forms. That workflow is basically, oh, look at that. Someone spent some time. Oh, they didn't check the box. I'm sure they meant to check the box, but they didn't check the box. Can't process it. Go over to the fax machine, send it back to Dr. Bekker's practice, and Dr. Bekker's MOA. Excuse me, Dr. Bekker, did you mean to check the box? Yes, I meant to check the box. Come on. So a really annoying workflow. 100,000 times a year? Ouch. So through this process, they were able to reduce that significantly. 94% reduction in the number of forms going back. That small percentage is more sort of clarification. So it's not really incomplete, but it's more, we asked this question, we got an answer. Oh, we don't quite like the answer. We need some more information. So again, incomplete-ish. So that was the one massive benefit there. To tie on with that is this auto adjudication process. So receiving these forms, going into the system saying, yes, fantastic, approved, great, and getting the notification right away. Because of that backlog, because of all the faxes sitting there waiting to be processed, sometimes some of these forms would get 3 to 5 weeks to actually get looked at, get reviewed. The vast majority of those now, automatically approved. Foolishly, we still fax the approval back to them, but that's the part two that this process to actually improve. So significant improvements there across the board. So we like that. And what this really did for us in BC is really proved out that this technology framework works. Smart on Fire works. It gives us the benefits from the clinical experience perspective. It gives us the data we want from the systems perspective. So this just solidified, yes, okay, great. Approved. We like it. We're going to actually continue to actually adopt this and actually go down this path. So the most significant project in BC right now is actually looking at the referral process. So we have a digital referrals and orders program that involved a procurement of a third-party vendor to help us with that solution. That involves integration with all the EMRs in the province. Okay, great. We know Smart on Fire works. We know the clinical experience is there. We know we're going to get the data. Great. This is a must-have. This is a part of the actual architecture, part of the implementation. So, from our perspective, we're all in. And the experience to date with that integration is yes. Once you've actually done the implementation once, the second one, easy. Third one, easier.
So that's the gift that keeps on giving, right?
Gift that keeps on giving.
Yeah.
Thank you, Oliver. Now, let's talk about how you too can do the renovation to get this beautiful form system in your province, for example. So, Andrew, let's say someone in the audience would like to implement something like this. Could you please give us some insights on how to proceed?
It's an excellent question, Frederick, and the approach here is this is all about the clinicians clearly in the experience. We talked about the forms receivers, but it's most likely that we are wanting to expand and grow the solution, add more forms, expand more vendors, et cetera, and so on. And at some point, there is a cost to this. Frederick alluded to earlier, right? We don't have buckets of money everywhere. I'm sure you folks are in the same boat, and so therefore, though, that funding is likely to come from somewhere. And so as we start to engage in this project, it's really important that all of those stakeholders are represented as we sort of start to formulate this initiative over the coming months. And we may find that there's some regulatory bodies with the forms that you're dealing with, and as you sort of refactor these forms in a new format, maybe there are medical authorities, health authorities rather, medical associations that are actually wanting to approve, weigh in, endorse, etc. And so the clinical aspect of this is paramount. And because as much as Dr. Bekker says, hey, I need that sort of similar experience. And so walking through, how come it does this and that? Well, I don't understand how I get from here. So you need to be able to kind of adapt to that in your design process. It's absolutely critical. But include those other stakeholders, because those are likely the stakeholders you're going to come back to, as the progress happens, and as you look for expansion later, and we're looking for money and approval later. Make sure those stakeholders are involved in this process, even if it's just from an information perspective. Don't try and boil the ocean, right? And as we were talking about here, we've picked some very specific circumstances, like we did in Ontario with MTO. They had a specific need. I've got to get this new form out, and at the same time, the clinicians themselves were frustrated with trying to find the forms and make sure that they were up to date, et cetera, and so on. So as you embark on this, Smart on Fire, we've been using the fire word for a few years now. There are folks that are starting to get some momentum building around this as well. So don't feel like you have to start this from scratch. Reach out, understand where some of this has been done before, and so that you're building on the successes and the lessons learned, which we'll talk about here in a second. The vendors, obviously, in terms of, we're talking about primary care, or at least community-based primary secondary care, that often predominantly means EMRs. Make sure the vendors obviously are involved in these solutions. We need to create the win-win out of this. And so what's really important here when we talk about then, so how do we get our footing on this? Frederick's comment about the money. If we start to control the environment that we're talking about here, okay, so let's focus on a particular form. Let's really get even on a what we call it, a pilot, an limited production release. Let's focus on 100 clinicians, 25, 50 practices, something of nature where we can actually control that environment is extraordinarily important, and we can probably size. Well, how long is it going to take to plan this? Like, let's not necessarily try and accomplish this all at once. How can we actually just sort of, what's it going to take to do the assessment? Which forms? Who do we need to engage, et cetera? And so, let's call that 3 months, 6 months. We can probably scope. We can understand, with reasonable accuracy, how much it's going to take to plan that. And then, and generally, so now to engage the vendors and get a little bit of coding done, to get the forms created, we now know what that effort's going to be. We can propose that second phase of execution and implementation itself. And so we're going to get into the lessons learned. What's really, really important out of all of this is we're going through this controlled exercise we know we don't always, there's always the critics out there. It's like, oh well, gee, I wish it would have done this, and oh, but yeah, but we can't put this out until we tweak this last little bit. So when we create this controlled environment, it allows us just to make some minor modifications before we actually sort of go and expand to broader sort of jurisdictional scope. We have the opportunity to really assess the gaps that are out there. The benefits evaluation is absolutely critical. And so when we think about, as we're now looking to get others to help us fund these initiatives and to gain the support, likely of the jurisdictions, the authorities, et cetera, and saying, look what we've got here, we need to build on this. What are the benefits that come from this? What is the value? The value from a clinician's perspective, absolutely. And so, it saved me time. It wasn't any, it didn't take me any longer. Oh, I got my, my responses back quicker. What about from the health system, right? And the data, et cetera, and so on. So you're making sure that all of those stakeholders that you're hoping are going to be funding you also see the benefit to them. If generally speaking, people who are giving you money like to know that they're getting something for their money, right? And sure, yes, clinicians, absolutely. None of this works without the success of the clinicians, but we're also trying to prove that value. So the lessons learned, we're going to hear a little bit about this in a second, the actual lessons learned that we took away from these projects. But the lessons learned are extraordinarily important in just as we now look to scale, what do we need to do a little bit different? Holy crap, well, next time we're probably better not do it that way. We need a little bit more of this and a little less of that, et cetera, and so on. And so back to the teams here, and we'll just talk about a little bit about what some of those lessons learned were for you folks as you might embark on this initiative.
Thank you, Andrew, for the framework and principles. And yeah, let's now continue in the lessons learned. So, Ian, can you please tell us what was learned in BC on the clinical collaboration and engagement front?
Thank you. Yeah, I was a little worried about these digital forms because, when you go to fill out forms in your day-to-day life on the web, some are bad and some are good. So I was like a little nervous because I am comfortable with paper, even though I don't like it. So I got a few GPs and some MOAs together to sit with the technical team as they were scoping out some of the foundations of what would be the way the form looked. And we would answer questions with them as they brought them up. And anytime we came across a question where we're like, well, I don't really know what the average physician would want, we'd send out a email to 30 or 40 other physicians, specialists, GPs, MOAs to say, all right, do you like A or B? And it'd be like, do you like, the data to go all the way down the screen and you scroll, or do you want to have the questions in columns, or do you want to have drop downs in this case, or do you want to underline? So we'd ask them very, very, very simple questions, and they'd give us the answer back, and we'd kind of go with the majority. So that was pretty important to make me feel like, all right, we're not going to make the forms look ugly. We're going to make them functional. And then that would be written into like a form standard in which every service provider that's going to make their own form, which is kind of cool, then they get to know what they need to do to make it look right. What are the parameters for how to make a form for this system? So they look fairly consistent too. How about in Ontario?
So very similar approach. We have something that we call the CAGs, which is Clinical Advisory Working Groups. Did the exact same concept. Bring in a group of clinicians, everything from family doctors to specialists to we even had emergency care doctors as part of the groups. And very similar concept. Hey, guys, this is what we're thinking about. Here's a wireframe. Yay or nay? Oh, okay, you don't like this, you like that. Cool, let's make another revision. How about now? How about this workflow? How about this implementation? How about, what does that look and feel look like? Oh, you don't like the questions in this order. Cool. Let's take that back to the stakeholder and figure out how we can make that better. It's immensely important. It's immensely valuable getting that level of feedback, which I don't think is probably lost on many here. But you'd be surprised by a lot of the feedback you end up getting. And so it's truly that important. And to be fair, not to say that the clinicians aren't important, but we had to consider the other side of the system as well, right? And so we had the other side of it too, where in Ontario we have what we call our monthly vendor sessions. We actually have all of the EMR vendors come in, join us once a month, and we talk through sort of the landscape, the initiatives, what's going on. And so there was multiple conversations about this, multiple rounds of requirements and feedback and conversations with these EMR vendors about what does this look like for you guys? How can we make this easier for you guys? For those monthly sessions turned into dedicated one-on-one sessions, and we refine to the point that I mentioned Ontario now has 5 Smart on Fire applications. With working with the vendors, those are plug and play. Those are as easy as installing an app on your phone. We effectively give them one single line of configuration information, and they put it into a configuration screen. Bang, new app is available.
Cool, just cool. So the IT collaboration engagement side, that's while I really enjoyed the physician engagement, it was a little too ticky boxy for me. It's fine. The IT, the vendors, that was really the key, because those are the folks that we need to partner with us to actually get this out the door. So I had a really fun experience with this. We brought all the vendors down to our Doctors of BC offices, and basically got them in the room, locked the door, said, do you guys have this problem? Because we hear it from the system side, we hear it from the physician side. Do you have this problem? Yes, we do. So over a long period, we actually got those folks working together, all competitors in the room, basically opening their Komodo, saying, okay, this is the problem we have here. This is the problem we have here. And I remember during one of these sessions, one of the guys is like, hey, oh, here we go, Oliver. Yep. I just got an email from a physician. Here. Can you put this form into my EMR? And it was I think it was a scan of a fax. And he's like, what do I do with this? So this was a pain point for them, which we were able to tap into to say, let's solve this together. So we identified that opportunity. They were a little distrustful of us, so we had to build some trust, because there were some non-technical issues we had to deal with first. So we went through that process, addressed some of the workflow, the administrative issues, built that trust to get to the technology solution. And by the time I got to, can we now talk about how we digitize this? What's our technical solution look like? They were all on board. We explored together. Anybody have any ideas? No, what about this? My team went off and actually explored. This is where we discovered Smart on Fire. We thought this is kind of neat. We went back. We provided education. So all these vendors, here is Smart on Fire education. This is what it looks like. Oh, okay, this sounds kind of cool. It hadn't been done in Canada yet. There have been some examples down in the States. So we basically went through that path together. They said, let's try it out. We did a prototype. This is what it looks like. Okay, cool. Benefit for us is we got to see how difficult it would be for the vendors. So the vendors, weren't just, oh, okay, well, what is this big black hole? No, we're like, well, you know what? We implemented this. It took us X weeks to develop this, X weeks to tie in. So they were bought into the whole process, and that really made it very critical. So that when we got to doing the initial implementation, great, a bunch of vendors put their hands up to say, yes, we want to do this. That said, BC, big, beautiful, small province in Canada, we knew that we couldn't do this by ourselves. We knew that some of the vendors in the room were national vendors, and BC's an afterthought for some of them because of just the market dynamics and the market share. So this is where the next big lesson learned for us was provincial collaboration. So when we were doing these having these conversations with the vendors, when we were doing our research, when we were building our prototype, you know what? We weren't doing it by ourselves. So this is where phone call up to Ontario. I hear you guys have the same problem. Oh, you're doing the same thing kind of around the same time. So this is where Ontario and BC really developed that relationship, developed that partnership, and went down very parallel paths together.
Yeah, that call from Oliver, starts off as this, hey, look at this cool thing we're going to do. And Ontario, again, having similar priorities, it was like, oh, okay, you guys are doing this. We're looking at something similar. Okay, yeah, this makes sense. And, a one cool call turns into bi-weekly meetings, turns into joint design sessions and data modeling sessions. And, Oliver talks about having fun with all these vendors in the room. And I'm unfortunately, I couldn't fly out. So I'm sitting there on a call listening to all the fun they're having. But it was a great opportunity for us to align. And that doesn't necessarily mean that the solutions are exactly the same, right? They're not identical, intentionally so. Every jurisdiction is going to have slight nuance. They're going to have slightly different needs. And, you can account for those things. But at the same time, easily 90+% of what BC did is what Ontario did, right? It was that easy. And it was that easy for us to learn from each other's lessons along the way. BC happened to be at one particular point, we could turn around and say, yeah, let's not do that. We're going to learn from that and sort of go another direction to save us some time versus going the other way where, Ontario was a little farther down the data modeling and it was just here, BC, open arms, take what we have, make it fit what you guys need now. Like tweak it here, tweak it there, especially if it came down to maybe even something that was form specific. That collaboration actually it worked so well that BC and Ontario actually now co-chair what we call a grassroots sort of collaboration session that occurs monthly, where it's just a forum for the various provinces to come in and discuss their priorities, discuss lessons learned. What did you guys do in another province? Hey, we're just starting this project. Can I learn from what you guys have? Can you share? And we have great participation in that, and it's open to any province or territory that wants to come in and share or learn.
Thank you, Chris. Collaboration is definitely a key in these type of projects. And for folks in the room, feel free to reach out if you're part of a jurisdiction and you would like to be part of this initiative that Chris just mentioned. Now let's hear Dr. Bekker for the conclusion.
All right. A form's renovation, or we could call it a revolution, because that's kind of what it takes to get the change done around here some days. So we've taught you, well, here's how you break the problem down. Here's how you figure out what you want or what your physicians want for all the different components. We've heard about some cool technology, Smart, that's going to allow forms to like pop up easy, and Smart can also bring all sorts of other cool apps into your EMR really easily once you invest in it. So we've learned about Smart, learned about Fire, learned about collaboration, learned about, got two handsome designers to come check if you want to do some implementations, you can hire them. So our message is Smart is great. If you invest in Smart today, it'll fix your problems tomorrow. Thank you.
Merci. Thank you very, very much, guys. Thank you for doing the trip all the way to Montreal and sharing your experience. I think it was very insightful and inspirational. So we have time for a few questions for folks in the room. So you can either, there's a microphone available, or you can just ask the question from your chair.
Alex,
go ahead.
Yeah.
Yes.
Yep.
Yeah.
Right.
It's open source.
It's
Right.
open source.
Well,
Standard.
So it's open for anyone. There's libraries that are available to make this stuff nice and simple to plug things in. Again, not to say that it's zero effort, but a lot of those libraries already exist, right? So from a technology perspective, it's, grab what you need. There's great documentation about how to plug it into things. And it's, I don't want to say it's as simple as plug and play for that first implementation, but it's not that far.
And you don't pay anyone.
I can start at least with the vendors themselves. They have their own challenges in this particular space as well, and so they're and as we were saying earlier, how do you create the win-win-win out of this? One of the earlier challenges, even just sort of step back a year or two, was fire. This new, it's just, as HL7 continued to expand, these are international standards as well. To your earlier question, and so the vendor community were, well, how do I learn this a little bit? It is sort of the next wave, and so the tools and whatnot that were available to the vendors was quite excessive. And also, it's important that what we've done here, using Smart on Fire, it's not just an e-forms thing. Right, it's a technology then that is extendable, not only expandable, but extendable to other applications, and so that is another thing that the vendors themselves are looking for. Please don't tell me that this is a one-off solution in this particular area. We're looking for expandability, repeatability as you go within the individual jurisdiction or you go across the country, especially more and more, right? We've got other topics around us that are, the vendor community say, can you guys like get together and like figure this out? So that, I think, if anything, was more the direction that we have to help the vendors along on this, is find that synergy, and so that it's not the one-offs.
And I'll add to that in Ontario, at least, we have a certification program for EMR vendors. Okay, so we have a real good foundation, is the way I'll describe it, where there are expectations of these vendors, including sort of to the point you're making about, hey, but I don't know that I want to map this data or I have it. No, we have a core data set. You have to have this minimum data set available for either extraction, utilization, or display, right? And so it was, we had a little bit of a leg up, if you will, that said, no, we get it. We're not going to ask for something unrealistic, but we know you have these 1, 2, 10, 20 fields, right?
Yeah. In terms of this idea that you can add other apps, I asked Chris what other apps he has, and he told me about this cool app that you can add with that single line. So the vendor adds the single line into their program, and then I get this new app that shows up in my EMR. It was a cancer screening app. So within my patient's chart, I can open this app, and it's going to connect with the cancer agency and give me a sense of where they are in their screening process. Oh, you have screened for this, you haven't screened for that yet. This screening's coming up, because it's reflecting what BC Cancer knows or what Ontario Cancer knows about the status of the screening for that patient. I was like, oh, that's really handy. So those are the kind of things we're projecting for the future once you adopt Smart, or the vendor adopts Smart. You can add apps. So I thought it was cool.
To add to that, adding them in the implementation we had, it's as simple as giving them a name. This is the name of the app I want you to launch. Right. Done.
And BC Cancer put work into the app, so that's how the work gets done to create this greatness, right? It's not free, but someone else did the work, and they're happy because then they get better screening and healthier patients, less cancers coming in, so they put the effort in to make a nice app to improve the screening done at primary care.
And on that note, Chris, maybe could you expand on the other apps? I think Dr. Bekker just mentioned one of them, but the other apps using Smart on Fire that's able to leverage the previous development.
Yeah, so there's 5 Smart on Fire apps in Ontario today. So obviously eForms was the first guy out the door, at least from a full app perspective. We have our Cancer Care Ontario SAR reports, which are available through that as well. We have a system called CRIS and HPG, which is community-based community care for patients at home. So there's a web portal for that. Clinicians can go in, see what the status is, see what's going on. We have what we call OTN e-consult. So it's a consult system that allows for clinicians to, just that, consult with a specialist on a particular patient. And I apologize, I'm forgetting the 5th one all of a sudden.
That's right. Clinical viewer?
Clinical viewer, thank you. Yes, and then we have an EHR clinical viewer called Clinical Connect, which again, same concept. It's just a set of buttons or a drop down. The design is based off of what the EMR wants to do. Like let it flow in their system the way their system already works. So if they want to create buttons, go nuts. You want to drop down, sure, whatever it is for them. But they select what they want, hit the button. off they go to the other app, whether again it's displayed as part of the EMR or external, with patient context, clinician context, all of it, right? I'm looking at patient Bob. When I click go and I go to the clinical viewers, I got patient Bob.
Other questions?
Yeah.
Maybe that's a question for you, Oliver and Chris, because you come from different organizations. Unless I'm mistaken, PHSA is a government organization, and Ontario MD is more of a not-for-profit association, right? So,
Yep.
my question is, where are you? How do you connect in terms of the governance to make sure that you can build this thing forward? Because Oliver talked about building trust, right? But who do the vendors have to look for? I thought government would be the authority, but where does Ontario MD comes in terms of the authority to build that out, or the legitimacy to build that out?
So I can start with that, and on behalf of the provincial jurisdictions, certainly in Ontario, Ontario MD is a delivery partner, and so we're more or less just as a delivery partner for the progression of services out there in community-based care, and so similar with Oliver Passadieu, similar with PHSA,
Yes.
right? And so that's we're effectively communicating with our respective delivery sort of objectives from across the province, with the support of, I might add, right, our jurisdictions respectfully. It's not us just being renegade.
Yeah.
There you go.
And not just that, I would almost say we're functioning under the mandate from them, right? So it's not just, hey, we're doing a thing, whatever. There's a collaborative direction
Right.
from the ministry, from Ontario Health, from with Ontario MD, that it's sort of, we're all pushing in the same direction.
Yeah, and out in BC, very very similar. So PHSA is really at least the group that I work in it has changed since, is a delivery organization providing services to various stakeholders. So in this case, for this project, we were actually working with the doctors of BC, working with Vancouver Coastal Health, which is a regional health authority, and actually getting funded by the Ministry of Health. So from a governance perspective, we had all of these partners at the table. But also another thing which really drove this the project in BC was what I call the form owner coalition. So you had special authority, 300,000 forms. You had medical imaging, they get 1 million forms. So they're also at the table too. Say yes, we want to support this. We want to move this thing forward.
Can I add one more thing on here too, which is extraordinarily important? You mentioned the doctors of BC and Ontario, the Ontario Medical Association. It's the advocacy, right, for the physician communities, and ensuring that as you're affecting doctors, we all know physician burnout, right? That's on everybody's mind, and so as we invoke change, right now especially, everybody kind of, wait a minute, wait. What are we talking about, right? And so, in ensuring that advocacy there, and so when we think about the jurisdictions, it is, yes, the digital health, but it's also the medical associations, health authorities as well. Very, very important. And when we think about the stakeholders, as we were discussing earlier, please, like, make sure, success includes those folks.
Yeah, we have 1 minute left. Maybe a last question. There's a question in the room.
Time for coffee.
Cool.
Hearing none, thank you very much for attending. Merci beaucoup d'avoir assisté à notre présentation. Bonne fin de conférence.